Okay, so I just want to start off by saying thank you so much for coming and agreeing to do this with us. Um, and so now you can just start whenever you're ready.
Perfect. So let me just pull up my slides real quick. Give me one sec. Oh, it says I'm not able to share my screen.
Sorry, I just let participants see the screen.
Perfect. Okay. So, hello everybody. My name is Abbas. I am a family medicine physician, and today we're going to be talking a little bit about family medicine, but I try to make it not as boring as I've seen presentations in the past. So I hope it would be interactive. I know we have a few people here online today, so feel free to jump in, ask any questions you have. And as interactive as this can possibly get, and the better. So, so who am I? So I'm a family medicine physician. I've done work in health policy. I did a fellowship in health policy through the AOA this last year. I'm going to be continuing my policy work with a community medicine fellowship, where I'll be working in the community with a lot of underserved populations and looking at the policy that affects their overall health. Before medicine, I was an engineer. I realized that I didn't really like the engineering job as much as I had anticipated, and so I switched over to medicine. And I'm also a musician. I do a lot of things in the arts, a lot of music. I'm not a very good physical artist myself, but I do enjoy it. And I bring this up because we're talking about medicine and what I do, but it's super important that you, as a future physician, realize that it's not all about the medicine. You have to be able to cultivate the other things outside of medicine that you enjoy, because that will help sustain you in the long run. So it's a little plug that I always put out there. And a lot more. I do a lot of things that would just take way too long to list out. So why medicine? So it's the one career that that you're really privileged to help people in their best and worst times, and it really is a privilege to do what we are doing. It is very hard work to get to the end of your training, but you will impact so many lives through your work. At the root of it, your job is really to advocate for a person and help them feel better. There's a lot of times that you're going to see a patient and not know exactly what to do. You're not going to know what it is that that will take away their pain or their anxiety or whatever it is. And the only thing you can do is sit there, listen to them, and comfort them. And it's really important not to forget that human side, because you can be the smartest doctor in the world, but if you can't connect to a patient, if you can't empathize with them, it's not going to make a difference. And it's also really, really, really fun. So we are really blessed to be able to do this job. So does everybody know who this is? Yeah, it looks like people are nodding their heads. Okay, this is Batman. If anybody doesn't know who it is, does anybody know why I put Batman up here? No. Okay. Any guesses? In essence, what is Batman? He's a silent hero. He acts. Yeah, I mean, all of those are really good, but when you break down what Batman is, yes, he's a superhero and all that, but he's a detective, right? Batman does detective work. If you watch any of the old animated series and even some of the movies recently, you'll see that he does a lot of detective work. Even if you play the recent Batman games, and that's what medicine is, right? It's a lot of detective work, and hopefully, I'll be able to highlight that with this case coming up. And yeah, it involves a lot of mysteries. It involves a lot of unknowns, right? You have a patient coming in saying, not saying that, oh, I have congestive heart failure, right? They say, I'm struggling to breathe. And you have to ask them questions to figure out what is it that is causing their dyspnea or the shortness of breath, right? So that's why I put Batman in here. I also love Batman. My cup, I don't know if you guys can see, is a Batman cup. So yeah, Batman is my favorite superhero. All right, so we're going to talk about a case. And I apologize in advance that these slides, the ones that I have here, are not the updated ones. So I'm going to make do as best I can. So we have little Jack here, right? He's coming into your clinic because he hasn't stopped crying, right? His mom came back from work and he just would not stop crying. Mom says that dad told her that he was eating and that he was eating fine during the beginning of the day, and then like the middle of the day, like late morning, he stopped eating, was crying, unconsolable, and she wants to know what's going on. So what do you guys want to know? Maybe he's in pain. Yeah. What else? Babies will cry, and that is a normal part of babies' lives. You just have to figure out, are they crying for like for food, because they have a soiled diaper? I think somebody said that, what is their history? He was a normal birth, very healthy baby, normal vaginal delivery, no complications. And he's about 8 months old. So you basically start with the basics, like, right? Who is with the baby? Allergies, yeah. So you can ask about allergies, see maybe he's having an allergic reaction. I think somebody else said something there. But like, who is with the baby? What happened? Was he like that in the morning? The mom says no. A baby was not like that in the morning. Baby was happy, healthy. Nothing like this has happened before. So something happened between the time mom went to work and the time that mom came home. And so mom went to work about 7 in the morning, left him with dad. And dad is not with the baby right now because it's COVID times. Only one parent is allowed in the room with a child. So anything else you want to know? So the other things that I would potentially ask, the food the baby ate, yeah. So regular food, his regular, rice cereals, pumped breast milk, nothing out of the ordinary. What I would ask is, like, is he acting any differently? Yes, he's crying, but is he acting any differently? Is he not moving a limb? Is he as active as he previously would be? Is he peeing and pooping okay? Basically, with babies and with children, it's you have to figure out what their baseline is and what their normal functions are and how they depart from it. And so for this baby, he's not really moving his left leg. And whenever mom tried to change his diaper, he was crying even more. It looked like he was in pain, and that's why mom brought him in. Any other thoughts? Okay. Is there a rash on the leg, maybe? There's some redness on the leg. The leg does look a little bit more swollen on the left. Yeah. Did he fall? Right? So that's a good question. And the way we answer it is by asking, like, what is it that babies do? Right? Do babies do 8-month-old babies walk? I don't know if you guys have ever worked with an 8-month-old before. Maybe he fell out of his crib. Potentially, yeah. Mom says no. And even if he did, the crib is very low lying, so wouldn't really cause any injuries. Does anybody know if an 8-month-old baby can walk? It's a hard question, right? Yeah, you don't think so. Most babies at 8 months old won't walk. What they will start to do is start to pull themselves up to a stand. By that time, they should be crawling more or less. So they can be crawling and pulling themselves up to a stand. Some babies, if they're very, 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 very advanced in their motor skills or like very early, they can start walking. A lot of times it's not very coordinated walking, they're falling a lot. Good. So here are the parents, right? There, you get some history from a nurse that kind of knows these parents. They come in themselves to the clinic and have gone to the ER a few times too. But from what the nurse knows is that they've been there's been multiple complaints of domestic violence against the father. Both parents have a history of substance use. They have 4 other children, but no previous history of child abuse. Right. So at this point, um, you should be potentially thinking about trauma to the baby, right? So did the baby fall, which would be an accidental trauma, versus did the baby get injured from somebody else, which is a non-accidental trauma, right? Did somebody hurt the baby? And I bring this up, and I bring it up into like lectures like these, just because this is something that you're going to see no matter what specialty you go into, right? At some point in your career, you will have the the suspicion in the back of your mind that, okay, did something happen to your patient that was non-accidental? Did somebody inflict damage or pain onto them? And so it's one of the things that we don't typically talk about when we talk to pre-meds or in med school. Even like it's not something that we get a lot of training on until like you're in your 3rd or 4th year doing a pediatrics rotation. So and non-accidental trauma is pretty common, unfortunately. So yeah, with this history of the parents, what do you guys think? Any questions or concerns that you guys have at this point? Because they have a history of substance abuse, would they still be reliable in terms of information? That is a fantastic question. And yeah, you would have to trust them. To a certain extent, you have to be able to trust the parents. You trust them to a certain extent, but the it's very easy, and I put this picture in specifically for this reason, because it's very easy to judge somebody on their appearance, right? What stands out to you when you look at these parents? When one of the parents were changing the baby's diaper, they may have been a bit too rough and they hurt the baby. That's possible, right? What stands out to you about these parents? And it's okay to state the obvious. I put this picture in because it's obvious. Yeah, their outfit, right? The guy here has a Nazi sign on his shirt, right? So you have this guy coming to your clinic, with a kid, and the kid has a potential non-accidental injury to him. It's very easy to say, well, this guy is not a good person and he probably hurt the baby, right? So would you be correct in that assessment, though? Yeah, but perhaps the environment of the baby's living in isn't stable, looking at the parents, potentially, right? But again, it goes to biases and prejudgments in medicine, which is can be incredibly dangerous. And I specifically put these pictures in to have this discussion, right? Because what happens when it's in a Latino parent or an African American parent, and the doctor does not have as much experience with these populations, and they have these biases, how easy would it be for them to say, oh yeah, this is probably a non-accidental trauma, and we need to call CPS on these parents, right? So yeah, the short answer to this is we don't know, and we probably can't say one way or the other if these parents are abusive or not, right? Even with the history of substance use, like, people go through what they go through. It's a history of substance use. We don't know if they're using right now, right? They could have used meth, heroin 10 years ago, and now once they had their kids, yeah, they might have what looks like racist tendencies, but they still love their kids. And do you take kids away because the parents may have like prejudice against people? No. So yeah, substance use doesn't automatically mean they want to hurt their kids. Exactly. All right. So if you have a suspicion, are you allowed to order a blood test on the parents? No, right? You can't test the parents because they're not your patient. Your patient is the kid. And you would have, if you have a suspicion, that the parents are under the influence, the best thing you can do is call Child Protective Services or social work to evaluate. Sometimes, well, actually, no, I don't even think law enforcement can ask for a sample from the parents unless they have, unless I think they're gonna. No, even if they end up arresting the parents, I don't know if they would be able to test without consent. That's a good question, though. Yeah, I'll have to look that up, and if I find an answer, I'll let you guys know. But this is one of the pictures that I changed because this is not indicative at all of what we would be looking at. So sorry about that. So I don't know if you can see my mouse. Yeah, you can. So this right here is meant to be redness kind of in the leg, and you'll see why it's not very accurate. This looks more like like an allergic rash. Maybe something contacted the baby's skin and it caused a flare up, like a contact dermatitis onto the skin, which is basically just an allergic reaction. So it's not super accurate, but pretend that this is some redness across the leg, right? You're seeing the baby's crying. You're trying to like hold him up and support him with the standing. He doesn't want to put a lot of weight on that leg, and he's crying. What else do you want to know? Damage to the muscle or bone. Perfect. How would you do that? Fracture. Okay. So we're talking about getting an x-ray. Yeah. So whenever we suspect some type of trauma to the baby, especially if it's non-accidental, we will get a series of x-rays. First and foremost, we want to make sure that there's nothing there on this baby. So we would get an x-ray of the femur or the leg in general and see if there is any fracture there, anything that's worrisome or suspicious. By this time, we have to bring dad in. And so dad comes into the clinic and tells you that, yeah, he was watching the 4 kids, and one of the baby's older brothers pushed him down the stairs. It was a short, it wasn't a lot of stairs, but he pushed him down. So what else do we want to know? So what ends up, how steep were the stairs? Good. Like how many steps were there are good questions too. Eventually, basically what we want to find out is was it witnessed or was it not witnessed? And dad says he wasn't there for it. Older brother is like 5, so he was trying to play with baby and pushed him down. He has like 5 steps that baby was pushed down. And so, if he has injury to the legs, the question is, does he have injury to anywhere else, right? Did he hit his head? Is he breathing funny? Is he kind of not moving any other limbs? And so the reason we want to ask, what his activity is because if a baby has a forceful trauma to the head, if they hit their head on something that's hard, they can potentially bleed. And if they have a brain bleed that is still pumping blood into the brain, that for babies, they have an opening, so you'll have like a bulging of a fontanelle. But as they get older, that kind of closes up and becomes more solidified, and you end up putting more pressure into the skull area, and it can cause damage to the brain, like strokes, or also if there's so much pressure in there that there's nowhere for the brain to go. The only way it can go is down and down into like the spinal cord area, and so the brain stem will herniate down because there's so much pressure, and it cut off all of the regulatory mechanisms that help you breathe. And so basically you end up herniating your brain stem, and you can die. So that's why it's so important to figure out, was there trauma to the head, and potentially do some CT scans or imaging for that area. At this point, would you inspect the baby further to make sure that there's no other serious injuries? Definitely. You definitely would. In the picture of the leg, the rash is bulging a bit more, whereas the regular leg is normal, not swollen. Exactly. So there's supposed to be some swelling here also. Again, this is probably more because of some rash that the baby has in this picture, but oops. And so but yes, this is supposed to be a bit more swollen. And for the baby, it's a bit more tender as well. You do the rest of the physical exam. He's moving his legs and his arms okay. He's just very hesitant with this leg. I think there was a little bruise on the belly, which I don't think I have a picture of. And then there was no injuries that were obvious on the head itself. Okay. So this goes back to what we were talking about before, right? So what are babies able to do? At 6 months, they should be able to roll over in both directions. They sit up with support. They begin to sit up with support. They bounce and support weight on their legs when standing. And they rock back and forth, sometimes crawl backwards before moving forwards. And the reason why I put 6 months and 9 months, the baby is 8 months. We don't have like really an 8-month milestone because that'd be incredibly hard to memorize and learn. So we have these little different milestones, so like 3 months, 6 months, 9 months, 12 months, 15, 18 months. And so we note these little changes. And basically what I tell parents is babies can be anywhere before or after that milestone time. So at 9 months, they should be able to stand, holding on for support. They can get into a sitting position. They can sit without support, pull to a stand, and crawl. If there was a bruise in the belly, should we palpate the abdomen? Yeah, we would definitely do that. We would definitely palpate the abdomen. Yeah, so this is important to know because if dad told you that his 8-month-old baby was running and kicked his leg into a dining room table or a coffee table or whatever, does that make sense? No. Exactly. Right? Why? Because he doesn't really walk, right? He's not walking at this time. He's 8 months. It would be pretty advanced for him to go running and hitting his leg into that coffee table. So this is why these milestones are so important. You'll have people come in with their kids that are like a month old and say that the baby rolled over and fell off his crib, and that's why he has swelling around the brain and a brain bleed, which doesn't really happen in a 1-month-old, right? 1-month-olds are not rolling around. And so that's why these milestones are so important when you're thinking about non-accidental trauma, because you have to say, does this fit with where the baby should be at this time, right? All right, so your exam, the patient is crying, appears to be in some distress, vitals are normal, he's mildly tachycardic, so his heart rate's going a bit fast. There's a bruise on the abdomen, and the baby's crying when you touch his legs. So we talked about getting an x-ray. Anything else you would want to do? There are some routine screening labs that we can get, but nothing necessarily like urgent at this time. So the x-rays are going to be the most important thing. If the baby's in pain, could that be why he's tachycardic? Yes, that's probably why he's tachycardic. Whenever a baby cries, they're basically exerting themselves, and so it's kind of like a little mini workout. So it's probably why he's tachycardic, especially if he's in a lot of distress. So this is just a stock image I got from Google, but what does that show? A fracture, yeah, a broken femur. So the question is now, does this fit in with the dad's story, right? Does pushing a baby off the stairs that are like 5 steps high, does that cause a femur fracture like this? Yeah. I see Michelle saying maybe not. I don't think so, not really. Yeah, the short answer is we don't know. This type of fracture is it looks more like a spiral type fracture. But if we're just saying that this is a fracture in general, it's possible. Depends on how hard they hit their leg, how forceful the push was, and that's why it's going to be so important to look for other injuries that can corroborate that fall, right? A lot of times, if you're being pushed down the stairs, you would have to probably hit something on the femur to get a fracture like this, and so it's becoming a little bit harder to believe the parent's story. But again, you have to suspend your biases as much as possible and be as objective as possible. So the other thing that we do is a skeletal survey. And can anybody tell me why we would do this? So what a skeletal survey is basically just x-rays of the rest of the body, right? So we get x-rays from basically head to toe, and we're looking for other fractures, right? So if they have a fracture in the femur, it's possible they have a fracture somewhere else. Exactly. So look to see if there's any other injuries. The main thing that we want to look for, and one thing that if you are taking board exams or ever tested on this, is fractures that are at different stages of healing. Why would that be concerning? Any guesses? A sign of repeated injuries, other fractures that weren't treated, injured in the past because they could have happened at different times. Exactly. So if you have a fracture that happened like 2 weeks ago, and then a fracture that happened today, the one from 2 weeks ago can already start showing signs of healing. The one today is going to look fresh, and there's going to be no healing around there. So there's ongoing trauma to this kid. A lot of times with babies, I focus a lot on the ribs because what some people will do is when they grab the baby, when they're really frustrated, they basically like push really hard and can fracture the back of the ribs, the sides of the ribs. And so babies that have like multiple fractures in the ribs are very, very concerning. I've seen babies with pretty bad head trauma and head fractures, fractures of the arms, legs, lots of different things. So the skeletal survey is super, super, super important. And whenever you guys learn how to do x-rays, it's important to learn how to read them, because When you're in clinic, there's not going to be a radiologist that reads it right away, right? You're going to have to be able to look through it yourself and see, hey, is there anything that's concerning acutely at this time? And for this skeletal survey, this one looks normal. The ribs don't have any fractures. You basically would have to follow each of these ribs through and see if there's any breaks. And it's hard because there is like shadowing between ribs. So this rib right here starts back here, and then this rib right here ends over here. So you have this area where it kind of looks like there might be breaks in the bone, but that's just because two ribs are overlying each other. So you'd have to go down each of these ribs and just see if you see anything that is concerning. You want to look at this, basically all the bones, the scapula, the humerus over here, and they'll have separate x-rays for each part of the body. And yeah, so this one looks okay. So he only really has that femur fracture. So what is your diagnosis, and what do you do? There is an obvious diagnosis of a fracture, right? So there is a fracture to the leg. So then the question becomes, is this accidental or is it non-accidental? Right? What do you guys think? Non-accidental. I have somebody for non-accidental. Somebody for accidental. Yeah. Because falling down the stairs should not break so severely. Yeah. That's the one that I showed you is a pretty severe fracture. But what if I told you that the baby had something like osteogenesis imperfecta, right? Where that's a condition where your bones are basically brittle, right? That's why I think somebody asked about getting the patient's history, like past medical history is super important. It's 100% super important, where if you have any disorders that causes bones to be more brittle or more easily fractured, then it is it's more plausible that like something like that can happen. It's a type of a connective tissue disorder. Yeah. I forget the actual defect, like in terms of if it was like collagen or what it was that causes the bones to be brittle. So it's like back in step 1 time. So it's second and third year of med school. But yes, it's a connective tissue disorder that can cause collagen is Ehlers-Danlos. I think I'd have to look it up. I'm pretty sure. Yeah, I'd have to look it up. Sorry. All the genetic stuff we don't deal with super often, so I don't really remember them. But yes, the patient's past medical history is going to be important for that regard, right? It's going to be important so that we don't push for non-accidental trauma when they have a good reason of fracturing that so severely. So what do you do if you think it's non-accidental trauma? What do doctors have to do? Call CPS. So you have to report it, right? You are considered a mandated reporter, and as medical students, you're going to be mandated reporters, right? Even if you're attending, or the person that you're working with does not think that this is a non-accidental trauma. They think that this is like, oh, it's totally fine. They believe the parent's story, but you have a suspicion that, yeah, I think that this is something that was inflicted on the baby. You still have that duty to report. And a lot of people get afraid of reporting and then like potentially ruining a parent's life or like the kid's life because they're going to be taken and put into foster care. But what I tell everybody is it's not your job to say like definitively that a baby was harmed, right? It's your job to have a suspicion of it and report it. What happens when you send a report is social workers will go out and interview the family, see if there's anything that would make them suspicious of child abuse. They would call law enforcement so that they can interview the parents as well. to see if there is a potential for child abuse. A lot of times an independent physician will evaluate them as well, and give their opinion as objectively as possible as to whether or not this is child abuse. So it goes out of your hands at that point. There's been a lot of times that I really don't suspect non-accidental trauma. Like I have this suspicion in the back of my mind that it possibly can be, but I'm like, it's less likely. But even that suspicion, I have called CPS, and I tell parents straight out, like, hey, I have to do this because I am a mandated reporter, and I have to be able to I have to protect children as best I can, and part of that is I am mandated to report this. And what will happen is a social worker will come out and talk to you guys, and they will evaluate themselves. My job from now on is basically to ensure that the baby is healing well and doing well. They will take care of the rest. And a lot of parents that are didn't hurt the baby, it was actually an accidental trauma, we'll be fine with it. They will say, I understand, do what you have to do. So it is uncomfortable, but you have to do it for the safety of the child. The last thing you want is to not report, and then the child ends up being a autopsy report after, right? So just a little bit about my job as a family medicine physician. And sorry, that case was based off of a case that I saw back in med school. I think that one actually ended up being a non-accident. It was an accidental trauma. I think once they interviewed the kid, the 5-year-old, and the older brother that was with them, the story was corroborated, and I believe he actually did hit his leg on something on the way down, and that's why it fractured. And so what they ended up doing, they did call law enforcement, and law enforcement, I believe, interviewed the parents, and the parents and like neighbors and stuff like that, and they were everybody said that they were extremely caring for their kids. Like they had never had any issues with the kids themselves. Obviously, things in this presentation were changed to make sure that anonymity was like preserved and all that, but the general story was very similar. So you will see this at some point in your medicine career. So hopefully this kind of gives you a framework to think about it, and also to think about what what some of the prejudices that one may have, and how that can affect like your decision making, and why it's so important to be as objective as possible. So what is my job as a family medicine physician? So I see adults and kids in the hospital, in the clinic. I can deliver babies. I can care for the women during and after pregnancy, help with mental health issues, end of life care. I can do minor surgeries. I cut out like lumps and bumps and cysts, and do biopsies, and all a bunch of different things. And we do a lot more. Like for me, I'm doing work in public health and health policy. I've done trainings in how to do forensic evaluations for asylum seekers. So there's a lot that you can do in family medicine, and your skill set is so broad that you are able to basically be dropped anywhere in the world and help people, which is really, really, really cool. There's not a specialty like family medicine. A lot of people think it's just a straight adult clinic, day in and day out. And yeah, a lot of people go that route, but if you have a desire to make your practice as varied as possible, there is a possibility to be as full spectrum as you can. So it's a very, very cool field to be in. And then I had a little plug in, like, if hopefully at some point, if I don't know if anybody was part of like my virtual rounding program in this last summer, I do hope to bring it back. So if you guys are interested in that, feel free to message me and contact me. And yeah, and that's all my contact info. That's how you can get a hold of me. Honestly, Instagram and TikTok seem to be the easiest way to get a hold of me, but yeah, feel free to send me a message. if you ever have questions. So any questions about this case, about family medicine, about anything at all? And I don't know how long I'm supposed to go for, but I'll be here till whenever you guys are done with any questions. Tips for somebody who wants to be a pediatric cardiologist. It depends on where you are in your training. If you're in high school still, or if you're in college, if you're like post-bac, whatever. I think there is not anything in particular you need to do if you're in like college right now to become a pediatric cardiologist. You would just have to get into a med school, right? It doesn't even really matter the like prestige of the med school, because to become a pediatric cardiologist, you have to go into peds first, and pediatrics is not as competitive as some of the other specialties like plastic surgery or like orthopedics. And so there's a lot of spots available for pediatrics, and so really for you it would just be get into med school, do well enough to match into the program of your choice, and then and once you finish your residency in pediatrics, you can go on and do a fellowship in cardiology. And that's how you do it. So it's not any different than any other specialty. You can always try to get more experience in it beforehand to talk about it in your application, but it's not 100% necessary. Did I ever consider other specialties besides family medicine? Yeah, I actually wanted to be a pediatric cardiologist going into medicine. But when I was doing my rotations my third year, I really enjoyed working with adults just as much as I enjoyed working with kids. And so there's an option to do like internal medicine pediatrics, IM Peds, which is a 4-year program. But I also really like doing obstetrics. So the only specialty where you can do all three is family medicine. So that's why I chose family medicine. I was an engineer before, so I was also thinking radiology, but there's not a lot of interaction with patients in radiology. You can do an interventional radiology residency where you're basically doing all the procedures that are like guided with like a CT scan or ultrasound, and a lot of that is kind of like putting in stents or drains into like the belly or other parts of the body. And because you're doing procedures, you have more contact with patients, and it's such a cool field, and it's also very rewarding, and there's a lot of procedures which a lot of people like, but I really like the continuity, and I like to get to know my patients very well and care for them. And the amount of human interaction that you have in radiology is definitely not as much as family medicine. Some people like it because of that, other people don't. So what's my favorite part about being in family med? Just that you can care for everybody. I think that for me, one of the coolest things that I've done is like in one day, I cared for like a dying patient, and it was able to like pronounce them and comfort their family, and which is incredibly hard. But like earlier that day, I delivered a baby, right? So you have like that full spectrum where you're like helping people as they go through the end of their life, and then bringing in new life, I guess, so to say. The other thing I really enjoy about family medicine in particular is that you can't really do in any other specialty is like I've delivered babies, I've cared for their mom throughout their pregnancy, delivered their baby, and now that baby, I'm now taking care of that baby as they grow up. And I'm also taking care of the mom and the rest of the family. So you can't really do that in any other specialty. What's the best tip you can give for those who want to specialize in working in pediatrics? Get involved as much as you can with kids. Part of pediatrics is being able to work with kids and be able to really convince them to let you do an exam. And you have to have a certain way with kids, where you're basically trying to be their friend in a way, and that helps, especially when they grow older and they go through like rebellious stages or whatever. Because when you are when you're a pediatrician, you have a lot of influence on that child, and so, as much as you can, if you can foster those good relationships with children, and teens, it will help you have a positive impact on their life. Um, yeah. Okay. I think, let me see. I think I missed maybe a few questions. Do I like outpatient better or inpatient better? I actually like inpatient a little bit better than outpatient, but I do enjoy both. The greatest challenges that I faced in my journey to become a doctor. Honestly, I had no idea I wanted to be a doctor. I had considered it early on. And so I really didn't have any guidance. So for me, it was like figuring out what I'm supposed to be doing, to apply to medicine. And so I think that was the hardest part for me. And then a lot of the interviews that I went on, they would always ask me like, why medicine? And for me, that was a little bit easier to talk about just because I had some experience in like in in the industry, in like in medicine in general. Um, but for a lot of people, that question kind of doesn't come out right because they focus on wanting to help people, but and then there's always somebody that says, oh, but you can help people in other industries. But what I would recommend for anybody that is going into medicine is really to sit and reflect as to why they want to be a doctor. A lot of times that is experiences within their own family, or their own experience within the medical field, and interacting with patients, or themselves being a patient, and really like solidifying that answer, because you will be asked that, day in and day out. The other thing that I think was a challenge for me, especially coming outside of like the whole pre-med track, was I felt like I was always behind, and it was never true. Everybody struggled the same amount as I did when I was in med school, but that imposter syndrome is super real, especially if you are outside of the pre-med track, which I'm assuming a lot of you guys aren't because you're part of this. So, but despite that, you're going to feel like you don't belong, or a lot of people are a lot smarter than you. Just know that they're all struggling the same. Um, how do you get kids to cooperate and tell you sensitive information about their social history? I'm just as blunt as possible, and I say, hey, like, whatever you tell me, I'm not going to tell your parents. I am not legally allowed to. I'm here to help you as best I can, and the only way I can do that is if you are honest and forthcoming with what I ask. And so I'm just a little bit more blunt with them, and a lot of it is just cultivating a good relationship beforehand and talking to them about their life in general, and having an interest in their life in general. Like if you are asking about their school and their friends and all that, and you show a genuine interest in their hobbies, when you come to ask like, hey, do you have a girlfriend, boyfriend, are you sexually active, do you prefer any particular gender, they would be they're a lot more forthcoming. So it's all about that relationship you build with them. What do you think about going to medical school outside of the US, such as the Caribbean, Australia, Ireland, if you have a low GPA? It's harder to match into a residency if you go outside of the US. It's not impossible, right? You have to have high board scores, and higher than average board scores to be able to match back into the US. So that's why it becomes a little bit more difficult. But again, it's not impossible. There's a lot of people that match into US residencies. I tell people that if you want to do something super, super competitive like orthopedics or plastic surgery, even neurosurgery, it becomes that much more challenging when you are training outside the US. So if your goal is to become a doctor and there's no other options for you, by all means do it. But just know that you're going to have to work hard throughout your 4 years to match back in. Since you said you considered peds cards, but you still liked working with adults, did you ever consider being an adult cardiologist? I did for a bit, but again, I enjoyed working with kids also. So I enjoyed the whole spectrum, and specializing in one thing didn't seem like it would fit me as well. So yeah. What do you think about BSMD or BSDO programs? Do you think there is a good idea? Do you think that going through the traditional route is better? Honestly, they are extremely competitive, and if you can get into one of those programs, I think it's way better. So that way you don't have to stress through the applications later on. So if you can do it, I say go for it. And it helps in the long run, because I think you finish more quickly, and you have to focus a little less on like the admissions process, which is very stressful. So I think they're a good idea if you can do it. What was your passion that led you to being a doctor? So when I was working with a company out in California I was a biomedical engineer. So I was working with a company out here in California, and at the time I had been volunteering at a hospital, one of the public hospitals out here. And what I did when I volunteered was I played music for patients. So I would go to patients' rooms, talk to them, play them a song. A lot of the people that I played for didn't have any family, and it was like the first time anybody really interacted with them outside of the medical staff. And so the relationships I was able to build and learn about and talk to people where it was really impactful. And I speak Spanish. I come from a family of immigrants. My mom was born in El Salvador. My dad was born in Pakistan. And so I grew up more with my Spanish speaking side, and I saw a lot of the struggles that they went through to get in to see a doctor. And so when I spoke to some of the Spanish speaking patients there, they kind of pushed me. It's like, hey, you should consider being a doctor. And that's kind of what made me consider it more seriously, because the way that they put it is I had a skill that not a lot of other doctors would have, and that is being able to relate to a community that desperately needs help. So that's kind of what pushed me a bit more into medicine, and I enjoyed working with those patients a bit more than my actual job. So yeah. What is biomedical engineering? It's basically applied sciences, so engineering to biology and medicine. So we look at different diseases and how can we design devices to help with that. So for instance, the easiest way to give an example is if you have like an amputation of your arm, can you make a prosthetic and design a prosthetic that becomes more responsive, that's easier to use, that can provide feedback that you can program to respond to neural stimulus into like the musculature around the area that you still have. And so it's like engineering to make medical devices, basically. Cool. Any other questions? What made you switch from biomed engineering to medicine? It was that I enjoyed the science. I didn't enjoy the work as much. The science is great. It's super fascinating. I can learn about it and do it all day, but it's in the end, what brings me more satisfaction in my job is working with people. So that's what kind of pushed me to switch. Any other questions? Do I use calculus as a doctor? I think you use the inherent knowledge of calculus and physics and biochem and ochem and all that. You don't sit there and say, oh, I'm going to calculate the integral of whatever to treat this patient. It's more of like, so I can give you an example. So when we look at the pharmacodynamics of a medication, a lot of times we're looking at what how well a medicine penetrates tissue, how well it goes into the bloodstream. If you take it by mouth, how available is it in your system? Because a lot of it will be digested out, basically. So we use calculus for that to calculate like the areas under curves, to be able to decide how much like of a concentration is going to be inside somebody's body, stuff like that. So we do use the fundamental knowledge of calculus and biochem and all that to understand medicine. But after you've been out for a while, you no longer have to revert back to the basic sciences. You understand it like fundamentally, if that makes sense, and you don't have to kind of go back and think. I myself, a lot of times, if I don't understand a certain disease process or a certain medical topic, I will try to understand the basic sciences, because that will help you have a more fundamental knowledge of that disease state. So I still think it's really important to have an understanding of it, but you don't have to be an expert by any means, if that makes sense. Do you think that stats is better, especially when interpreting medical research and studies? Yeah, stats is super important to know. You're going to have to deal with that a lot more than you would calculus. So it's important to have a good grasp on stats. Other questions that you guys have? If not, then, my contact info is here. Please feel free to message me. And thanks for having me. Hopefully this was enlightening in some way, shape, or form.
Yeah, I just want to end it by saying thank you so much for coming again and talking with us and answering all of our questions. I loved your presentation. It was very interactive and engaging, and it helped me learn a lot about family medicine. So, again, just thank you so much for coming.
Not a problem. And again, feel free to reach out, guys. I'm happy to help however I can.
Thank you.
Thank you.